Well, thank you for the kind invitation. I'll ask this is my first trip to Egypt, and it's really been excellent so far. I'm very honored to be part of this course and the distinguished faculty that is involved with the presentations today. So I was asked by Professor Greenhalgh and Thilo to talk about the NICE guidelines and how they would affect the North American EVAR practice. These are my disclosures. NICE, or the National Institute for Clinical Excellence, role is to improve the outcomes for people using the NHS and other public health social services by producing evidence-based guidance. And as you can see on the right side, they have a lot of engagement by both professionals, politicians, public, and a variety of other stakeholders in the outcomes. The name of the institute was changed in 2013 to the National Institute for Health and Care Excellence, but it's important to realize that even in the UK, it does apply to England and Wales, but not to Scotland. It's supposed to evaluate new drugs and different treatments for NHS coverage and what treatment represents the best value for NHS money. So far, NICE has issued about 100 guidelines, but you have to also recognize that only about 75% have been approved by the NHS. It is a highly regarded and transparent process that goes beyond the UK in terms of its influence. However, not every single decision by NICE has been regarded without controversy, and there's a list of several treatments and drugs that have caused a significant amount of discussion in the past regarding their recommendations. The topic that NICE reviews is typically prioritized by the Department of Health, and a committee is next formed with a chair that's supposed to have no conflicts of interest and a multidisciplinary panel including patients and a NICE team. They use a lot of evidence from the literature, but they prefer randomized trials and certainly UK data preferentially. Then they issue draft guidelines and ask for comments from all the stakeholders before the publication of final recommendations. That is next followed by implementation and review, usually in 5 years. This is where the process of the AAA guidelines is. There has been many stakeholder comments, but no final publications yet. The process was started in 2015, and there had been 17 meetings, 24 evidence reviews, 1 equality impact assessment, and 1 detailed economic model appendix that details the recommendations. And the draft guidelines were published in May of 2018 with a presumptive final publication to be in November of 2018. This has been delayed so far at least twice, initially to July 3 and now to November 20, 2019, because of the difficulty in getting a consensus. These are the draft guidelines. You are all familiar with them. The recommendation essentially for any patients with open surgical suitability is to undergo an open surgical repair without EVAR, and those who are unsuitable to essentially have nothing with no recommendations for EVAR or open repair, and essentially nobody with complex EVAR should have a procedure except for a randomization in a trial if it exists. In terms of ruptured abdominal aortic aneurysms, the recommendations are somewhat similar except for consideration for EVAR, especially in women. And again, no complex EVAR except in the framework of a randomized controlled trial. Now, clearly, the recommendations of NICE have been dramatically different from any other practice guidelines, including the recent ESVS and SVS practice guidelines. And they have generated a fair amount of pushback from the societies in the UK. And there's been a political process that has also been entertained to influence the NHS from accepting these recommendations. Ultimately, there has also been, my slides are not advancing anymore. Here we go. there's been some pushback by industry and a variety of other stakeholders. You have to understand that NICE essentially studies a problem from a multitude of perspectives, but by far the most important is the cost effectiveness of a particular treatment. To understand this, we better understand some terminology. First is the QALY, which is the quality adjusted life years, and then the incremental cost effectiveness ratio, or how much money do you have to pay for each additional QALY. But then depending on the country and the particular situation of societies, the willingness to pay can be quite different. For example, in the UK, any treatment that costs about £20,000 per QALY is considered to be cost effective, while in the United States, $100,000 is considered to be cost effective. So clearly, if the price is in excess of these willingness to pay, it is considered to produce population harm, as it takes away resources from other issues. And these are the thresholds in the UK. If it's over £30,000, it would not be offered by the NHS. They're not moving again. Here we go. So this is the data summary of the NICE guidelines. It relied heavily on the major randomized trials, and the critical component is the 8 to 15 year AAA specific mortality that was found to be higher with EVAR than with open surgical repair. This has been mostly derived from the EVAR 1 trial, where the outcomes after 8 years showed a significantly lower mortality for open repair because of the aneurysm ruptures that have been noted in the endovascular option. And this is the portion of the Kaplan-Meier analysis that was used mostly to derive the guidelines. So in the economic analysis, if you consider the costs, you will notice that all of them are significant when it comes to essentially the fact that there's very little QALY added by EVAR, and all of them found that essentially either EVAR is dominated or it costs significantly in excess of the £30,000 threshold, and this is the probability of anything being different. So what are the major issues with the NICE guidelines? Is most of the data is essentially more than 20 years old, and devices have improved. There's plenty of data. This one is from Italy that suggests that new devices behave better than older devices. The operator skills have improved, both the imaging equipment, and finally the follow-up schedules that we'll hear more about from Professor Greenhalgh have changed from CTs to ultrasounds, which is cheaper in most countries. And these are some of our papers regarding the follow-up schedule that shows that duplex can replace CT scan in the majority of follow-up, and that the 6-month follow-up is essentially redundant. Finally, the interventions on type 2 endoleaks, which used to figure quite heavily into the cost of the EVAR arm, has been changed with much less interventions performed on type 2 endoleaks, except when they enlarge significantly. And the recognition that both open surgical repair also has a significant number of intervention, and this is data from the Medicare database that suggests that actually both groups, the open surgery and the EVAR group, have significant reinterventions, and the cost analysis that was provided in the NICE study does not include the open repair reinterventions. Other failures of the NICE guidelines is there is no consideration for anatomy, for patient choice, for the risk of rupture in unsuitable patients, or for the lack of current open surgical skills that has become more and more of a problem in the vascular surgery community, the lack of availability of ICUs and OR facilities that will be taxed if you go back to open repair, and the fact that endovascular skill will deteriorate if you avoid the elective procedures, so that cannot be actually truly offered for ruptured patients. As far as the US and Canada, usually there has been in the past no impact at all from the NICE guidelines, and the demand for EVAR remains quite high about both patients and physicians in North America. However, I can see that these guidelines may stimulate some EVAR reviews by payers because of tightening budgets and increasing health insurance premiums in the United States and Canada, and with decreasing profit margins for hospitals. And there is a possibility that some restrictions may be enacted to limit the excessive use of EVAR, which is not necessarily all that bad. Now, the process is quite different between the US and Canada. Canada has a national health insurance that can dictate actually what happens, but in the US, it's much more decentralized, and the coverage decisions are not very easy to come by. So why I suspect the impact of NICE will be very limited in the US, that essentially all practice guidelines in the US support EVAR. The industry lobby is quite influential. Expensive treatments are well tolerated in the US compared to other countries. We do not have a national health insurance, and there's considerable competition among hospitals and insurance plans that will prevent them from withholding treatments such as EVAR, and the cost-effectiveness threshold in the US is substantially higher. Plus, the clinical data in the US support the continuous use of EVAR. This is a chart of the health expenditures across the globe, and you can see that the USA still has by far the highest level of expenditure, and the same cost effectiveness analysis of NICE will not actually work in the US. This is the only part, even by NICE guidelines, the only trial from the US, the OVER trial, that actually shows a cost saving for EVAR with a quality increase that actually makes it dominant. This is the economic analysis from OVER, and the bottom right quadrant is for the endovascular repair being less costly, and this is the total cost difference of the EVAR, and you can see by the vast majority of patients fall in that right lower quadrant, showing that there's actually less issue with EVAR in the US, at least by the OVER analysis. This is the data that was just presented from the VQI at Hamburg about 10 days ago from the VQI, as I mentioned, and it considered 4-time cohorts, and it shows that actually the long-term survival has been improving over time after EVAR with better selection of patients, while after open surgical repair, it has not been improving significantly. Now, when the two cohorts are compared, this is from 2003 to 2006, you will notice that the open repair has a slight advantage over the endovascular repair, but in the most recent cohort from 2014 to 2018, there's some reversal with the EVAR having a better survival up to 4 years compared to open repair. So my expectations is that the NICE guidelines will be published, but adoption even by the NHS is questionable and at worst may be delayed. With some accommodation regarding the application of those guidelines will be necessary, at least as a transition, to allow EVAR to continue in many centers permanently. And they may influence the future of EVAR outside the UK, especially in countries with limited health resources, but probably not in North America to a significant degree because of completely different economics. Thank you for your attention. And